today we'll be talking about total shoulder arthroplasty and reverse total shoulder arthroplasty. My name is Trey.
I'm Tia.
Elizabeth.
Alright, so the objectives, we're going to define both, state the indications of both, the precautions of both, the contraindications of both, the methods of both procedures, the rehab process of both, and of course give an overview. So, on page 629 of the a TSA is defined as a procedure done to replace parts of the shoulder joint with artificial components. The components are replaced are the humeral head and the glenoid. It typically is reserved for elderly patients with cup deficient arthritic shoulders.
And then next, so for a RTSA or reverse shoulder arthroplasty, according to Dutton in the clinical pearl on page 629, it defines what it is. This type of procedure is used in place of the original shoulder joint, mainly like where parts of the rotator cuff have been compromised or like damaged over time. So what happens is that the humeral aspect that is used is made from a concave socket, and the glenoid aspect is going to be more of like a base plate with like a glenosphere from what is stated in the clinical pearl. And these two components work together to help with like rotation both medially and laterally to sit around that, to also give the deltoid mechanical advantage, and giving it a mechanical advantage helps with increasing overall movement and recruitment within the deltoids to allow the prosthesis to be able to be set up correctly and take slack for the take up slack from where the rotator cuffs have been damaged and were compromised, mainly within the shoulder elevators.
Alright, so on page 630, the primary indication for surgical intervention is unremitting pain rather than decreased range of motion after a failure of conservative measures. The source of pain could be due to many types of arthritis, such as osteoarthritis, rheumatoid arthritis, and post-traumatic arthritis. It also states Paget's disease could be a cause, and that's a disorder that disrupts the normal process of bone remodeling, where old bone is broken down and replaced by new bone, and it could cause like damage to the shoulder joint. Osteonecrosis could be an indication as well, and all of this is the blood supply to your bones are disrupted, and that could lead to like bone cell death, and that could make it necessary for a TSA as well.
So the largest indicator for RTSA is compromise of the rotator cuff integrity, meaning that the muscles in the rotator cuff cannot be restored. So the RTSA serves as a way to completely resurface the glenoid fossa and humeral head, which is necessary for the chronic deficiency of the rotator cuff. And according to Kisner and Colby, if a regular TSA is used for a rotator cuff that is chronically deficient, superior migration would occur, leading to an increased risk of loosening of the glenoid implant, in addition to premature wear, which is why you want to do an RTSA instead. So for a cuff tear arthropathy, a patient may present with rotator cuff dysfunction and end-stage glenohumeral arthritis, and this will eventually lead in the collapse of the humeral head, indicating the need for an RTSA. And also in chronic soleal paralysis, the patient will not be able to use their upper extremity, especially if there is a massive rotator cuff tear that cannot be repaired, so they would have to have the RTSA. And then in addition to post-traumatic arthritis, like glenohumeral dislocation, tumor, and acute fractures. And I also included a picture of a beautiful shoulder joint versus this one down here where you can see the humeral head is superiorly migrated, which is an indication for the RTSA, because the rotator cuff muscles aren't keeping the glenohumeral where it should be. If that makes sense. Okay, so for precautions for total shoulder arthroplasty, you want to gather a baseline before surgery, including range of motion, muscle strength, and also want to implement some shoulder stretching. Post-op, you want to use stabilizer sling, especially for a rotator cuff repair. And then I also have for 0 to 3 weeks maximum protection. It's prohibited to do any type of shoulder active range of motion, especially greater than 120 degrees of elevation. Internal rotation, external rotation, and abduction. It's prohibited to lift items or have their body weight support on their hands. At 4 to 6 weeks maximum protection, it's prohibited limb extension, excessive external rotation, abduction, lifting objects. So really just lifting objects in range of motion is prohibited throughout the phases.
And then, so for some precautions for the reverse total, from an article that I found, of course, you wanna make sure that the patient presents with proper, with indications that they can actually plan for this type of surgery, especially when we look at like different imaging, like for diagnosis, like MRIs, x-rays, things like that, because if there's not enough imaging, this can like lead to challenges in being able to incorporate the surgery, because the article that I found by Waletsky and colleagues said that basically like due to wearing of patterns within the rotator cuff can affect like how the overall positioning of the prosthesis can be used for implants. And you also want to make sure with any patient, always review medical history. Some of the big ones that I found in that article, they said was like any history of like bleeding and clotting, if they take anticoagulants of any kind to help with clotting, and any type of other medications under that area. Some other modifiable risks that it mentioned were like obesity and osteoporosis, and what they said in their article is that some of the things like obesity can like affect the overall like stability of the prosthesis put within the joint, as well as people who have a history of osteoporosis due to that condition, nature of that condition, causing like bones to break down and become weak. That can also cause issues with the implant and overall outcomes over time. And then you also want to make sure that the surgeon is rather knowledgeable on the skill, because that can also affect how the procedure is going to go. And another thing that I found like preoperatively was infection that can occur, mainly preoperative prophylaxis, because around the area like where the shoulder is, especially within the axle, there's like a lot of different glands and hair follicles that if they're not cleaned properly, that they can become infected before surgery, and that could also like affect like how the outcomes can come along. It did mention some scrubs that you could use, one of them being I'm probably gonna butcher the names of these, but one of these being peroxidine gluconate and benzoyl peroxide, which both of these have been shown to help like lower the overall development of culture bacteria within the area. But there's not like enough like evidence out there to show like how much of a significance that they have. But the healthcare improvements project did say that patient should use either one of these scrubs for 3 days straight before the surgery to help with lowering that bacterial infection.
Okay, so here are some of the post-op precautions for an RTSA. In comparison to a regular TSA, an abduction splint is required, whereas for a regular TSA, if they haven't had a rotator cuff repair, you want to stop using the sleeve during the day as soon as possible, unless you have a rotator cuff repair, then it's required to use in a regular TSA. But for RTSA, the abduction splint is required, and it's used continuously for 3 to 4 weeks, and only taken off for hygiene and exercises or passive range of motion. And I also wanted to point out that throughout the whole phase from maximum to minimum protection, range of motion is prohibited in a lot of these phases because you have a lack of range of motion due to the way of the limit faucet becoming convex and then the humeral head becoming concave. So I was like, it makes sense to me because you go from like convex and concave to totally like this, and it's a lot more range and it's a lot easier to glide versus this is kind of like, you know, little resistant maybe.
Alright, so some contraindications may include infection, since it can possibly lead to impaired healing or the chances of an infection spreading elsewhere. It also says a neuromuscular disorder or dysfunction, since that can cause weakened muscles, which can lead to instability and possibly increasing the risk of a post-op dislocation as well. It's also listed a deltoid muscle dysfunction, since the lack of muscular support from the deltoid muscle can cause a improper prosthesis alignment and function. Bone loss will compromise the ability to securely anchor the prosthesis component, and also says young age. This is typically for people like elderly people. So if you're younger and you're like more active, it could lead to like a wear and tear of your prosthesis a little quicker.
Some of the contraindications for an RTSA are deltoid impairment. Without use of the deltoid, the surgeon won't be able to work because the surgery places the deltoids at a mechanical advantage to compensate for the rotator cuff muscles. And then also a supraspinatus tear. If it's able to be repaired, the shoulder can be balanced, meaning that it is able to be lengthened or tightened to restore as close to normal resting tension in the muscle tendon unit. And so because it's still usable, RTSA would be contraindicated. And then also full shoulder elevation, active range of motion with a rotator cuff tear without arthritis for the same reasons about the supraspinatus tear, in that the shoulder can still be balanced.
And then so the overall methods for, this is gonna be a few slides for the total shoulder, but for total shoulder in Dutton, it did state that this procedure is a rather arduous one, mainly due like to the skill, how much soft tissue has to be repaired, as well as overall placement within the implants and the overall rehab process. So of course, before any surgery, you want to make sure you monitor the vitals before and during the surgery of your patient, and of course, make sure, at least on the source that I found, it did say to make sure like you draw the incision marks beforehand to know like where to go, and also make sure that you give anesthesia to, and also to make sure that when you make the incision, it's going to be made around at the top of the shoulder, through the muscle, around the curve of the deltoid. From there, then the humeral head will be dislocated from the glenoid and will be taken out. Where the surgeon removes that, they're going to use a tool known as an osteotome to remove that out, to get rid of like any bone spurs or like any other like extra bone into the area because of the arthritis. And then a bone saw is used to remove the humeral head, and then using the humerus, the humerus is prepared then for the prosthetic, and then a reamer is going to be used to help smooth down the glenoid within the socket to help prepare it for the prosthesis to be fitted. And so from there, once the glenoid prosthesis is made, it's also going to have a concave surface to it made out of polyethylene, which has pegs to help back it up hold it into place. And with that, they'll also then put they'll also put a prosthesis to be fitted with cement, or if cement's not used, you can use press fit components to help help with that. From there, they use a temporary ball to test the stability. Once the stability has been tested, they'll remove that and of course make a mold for the patient based on what anatomy that they have left. And then they put another ball in to help test the overall movement. And then once that's been done, they dislocate the joint and test the movement again and put the permanent ball in and then close the incision up. Okay, so the methods are not as long for an RTSA, but again, you would do the anesthesia and take vitals as well. The incision is also made at the top of the shoulder, around the deltoid and through the muscles beneath. And of course, after that's been done, the surgeon's going to remove like the damaged parts of the humerus and scapula that were causing the pain within the patient. And from there, they're then going to insert like a metal plate that will take part of in the socket within the joint, and we'll put a ball in to the plate to help with movement. And once that's been done, the prosthesis will be put in with cement, and we'll have the socket fitted into the area. And once that has been done, any like excessive fluid will be drained out, and overall, again, the incision will be closed up.
Alright, this rehab process came straight from your therapy exercise textbook. I just tried to reword it for the most part. So the max protection phase lasts up to about 4 weeks. The goals are to control inflammation and restore your shoulder mobility. That would include some passive range of motion, active assist range of motion, some pendulum exercises, light isometric exercises. And of course you would loop the shoulder, keep the shoulder in the scapular plane. It also said to avoid internal rotation. Your subscapularis is in a vulnerable state after this surgery, so you want to avoid any internal rotation that could possibly damage your subscapularis. Now as far as the mild protection phase, that's about 4 to 12 weeks. The goals are to progress range of motion, stability, and enhance muscle performance. That would include rotation exercises, flexibility training, and closed chain isometric exercises. And an example for closed chain could be like a wall slide, and of course you would do that wall slide in the scapular plane. The minimum rotation phase is about 12 weeks or more. The goals are to enhance stability, neuromuscular control, and return to function, whatever that means for your patient. In that stage, like I said, you would do more ADL specific tasks, and of course in all 3 stages, you would include patient education, tell them why you're doing what you're doing, and how it will be of benefit to them. And on our next slide, we do have a couple pictures of some specific exercises you could do as well.
These were just some of the different exercises that we found from some of our sources. Maximum phases, Trey mentioned, you can do pendulums. One of the other sources other than our textbooks, it was like a protocol for total shoulder arthroplasty, said that you can do like rolling on a wall. So you might do like those exercise balls and just kind of like do the hand like back and forth, like so. And then for the minimum, one of the ones that we found was the push-up plus.
Okay, for an RTSA rehab process, max protection is only 0 to 6 weeks. Your goals are going to be to protect the joint, minimize swelling and pain, range of motion maintenance, passive range of motion of the shoulder, also patient education, and treatment plans. You can include some grade 1 or 2, or grade 1 and 2 joint oscillations, pendulums, isometrics, targeting the scapulothoracic and deltoid muscles, good human joint passive range of motion, active range of motion with elbow, wrist, hand, and isocompression to minimize that swelling and pain. And then 7 to 12 weeks is your moderate protection phase. So the goals are kind of the same, but you also want to, in this phase, you want to start implementing muscle strengthening of the deltoid and periscapular nerves, also motor control, and yes, you. as on the treatment side, you want to strengthen the deltoid and periscapular muscles. You can also start including submax isometrics of the glenohumeral and scapulothoracic joints. You can also do some dynamic elbow and wrist strengthening. Yes. Or endurance exercises too. And then weeks 12 or greater, your goals are to have pain-free range of motion, you'll implement rotator cuff strengthening, increase shoulder strength and endurance, and you want to have functional use of shoulder, and full activity return should be had in 12 plus weeks, after 12 or more weeks.
And these were just some other exercises that were found with for our TSA. You can do like shoulder flexion while sliding on a table. You can hold a cane or like other type of rod that they may have in the clinic, and do like sitting shoulder elevations. And also when you get to the minimum protection phase, you can do different PNF patterns, whether that be like D1, D2. And then so for our overview, so both of these procedures are used to help like with to replace either like the femoral head or the glenoid or parts of like the rotator cuff. Some indications, there was a lot. One of the ones that we saw a lot was usually you see them with like an elderly patient. You could also see with like Paget's disease, fractures, tumors, as well as like post-traumatic arthritis. There's a lot of different precautions as well, even like ROM or not going like over ROM after like a certain time after the surgery, lifting objects. Some contraindications, as Trey mentioned earlier, like bone loss, infection, as well as like deltoid impairment, and of course methods. As they go through the whole methods, is of course is setting up the prosthesis and replacing the damaged parts of the joint, and overall rehab process, just to make sure to follow the protocols that your therapist sets up for you once you're in the post-op phase. Any questions? These are our references. Emery, I saw your hand first.
My question is, what is the likelihood of any arthritis after these procedures?
I would say that just depending on the individual, how they go through the rehab process, that it could affect arthritis coming back or not, is what I would say, but I would need to go and research that some more. Any other questions? Ebony?
I remember on both the contraindications, y'all said something about deltoid impairments as a contraindication. Do you think that if they train first to get that built back up, they'll be able to have the surgery, or do you think it'll make it worse and it still won't impact them?
I think for the deltoid impairment, it's like it's not able to be repaired. So it wouldn't, if that makes sense. Because that's why it would be contraindicated. But I think that if you could strengthen your deltoid muscle to get it to where it needs to be, I feel like the surgery would be appropriate.
I feel like somebody had this question before, but I can't remember the answer. But after this procedure, like the humerus is the convex and the femoral is concave, and this kind of flips that. When it comes to the intervention, are we looking at that differently as well? Like, instead of there being convex and concave, we have concave and convex with the motion stuff, or do you just kind of keep it the same?
Well, a big difference was just the range of motion precautions. And so I stated earlier in the PowerPoint that even like starting from minimum to maximum, you always have range of motion precautions. You don't want to do, you know what I mean? If that makes sense. And so like I did with the, I enjoy like, okay. So it goes from being all this motion you get here to, you know what I mean? Like it's harder to move, and so your range of motion is not as broad, and so you don't want to, I guess, overstress that.
Kendall?
You mentioned something about a press fit. Can you go into the components?
So, from like, what little research that I found is like, if they don't use cement, they can get like little press fit components put into the joints instead to hold it into place. These are like little kind of stems, kind of like rods that are used to help hold the like humoral aspect of the prosthesis in place within the glenoid, and that just helps to put it into the bone and keep it into place there.